This is a recording for chapter 16. We're going to be talking about economics and healthcare delivery system. Um, as we know, there are a lot of trends that are going on now that are affecting healthcare. As we speak, due to the change in the government, we've seen some. Well, we're going to be seeing more drastic changes in healthcare. So these are some factors that are affecting the healthcare. Your intrinsic factors, which could be population, characteristics, healthcare demands, employer-based paid health insurance. Your extrinsic factors could be things like availability of technology, prescription drug costs, and workforce costs. Also, we do know that there's some changes in the environmental changes also, so which affecting healthcare and healthcare delivery. We've seen a shift from like episodic payments, provider-based payments, fee for services care, and also patient-centered care. Providers are also are seamless. Or can the clients afford them, or and also other things that affecting the economic environment could be quality of care. We stressed in the significant of everybody receiving high quality care, equality, and high quality care. Also, we've seen another change here recently, where not recently, but some years ago, where the more focus is on patient-centered care. We're involving the patient in their care more so than we used to. Also, care coordination. As we talk about care coordination, it's where we collaborate with from a team approach, interdisciplinary team approach. And also, we're looking at data, analytical data, and then also quality improvement tools, quality improvement measures, also which we see has been, you know, um, implemented, several years ago, making sure that clients are getting the care in which they deserve, and also there are tools to kind of track and trend measures, quality measures that are put in place as well. So as nurses, we need to make sure that we combine our skills, our nursing skills. Also, we have to provide care from a business perspective as well, and to be a full participant in designing and delivering healthcare. Now, with that being said, we as what I say, clinical skills and business, you're not going to be able to work in an area where doing a lot of wasting. So if you notice, if you worked on like in the hospitals or on the floors or whatever, uh, central supply for an example, if you go in, not central supply, the supply room, getting like IV supplies, you know, things of that sort, bedpans or whatever, anything that has to be charged to the client. If there's like at the end of the month, the managers go and they do inventory. So if the inventory doesn't match up with the supply that they had in stock, then that unit could be losing money. So it's very important in a nutshell that you make sure you charge the patient, and then decrease things like wasting. If you're not gonna use a supply, make sure don't take it out of the supply room. And then again, make sure you use supplies with caution. You don't want to you know waste a lot of supplies. And sometimes when you take supplies out of the supply room, and take them to the patient room, they consider contaminated. So be careful with that also. Healthcare is a limited resources, and choices have to be made. So it's very limited. So we have to make resources scarce. So again, as we talk about in diverse areas, vulnerable areas where resources are scarce, so we have to make do with what we have. The Affordable Care Act, we beat that horse to death already, so I'm sure y'all understand what that means. And so, Affordable Care Act was a good act that was put into place because it also the good benefit of it that it provide care for those clients with pre-exist condition, and also preventative screening and services are also covered under the Affordable Care Act, which is good. Also, when we look making choices about methods to produce health care, we look at the right care, the right amount of care, the right provider, the right setting, and then again whether or not there's need for to research to to decide the best method. As we talk about the right provider, you wouldn't a client wouldn't be referred to a general practitioner if they had kidney failure, so they need to be seen a nephrologist. So what are the choices about allocation? So what are some choices? Is healthcare is a right or it's a commodity? You know, based on the American Nurse Association, we as providers must provide care without consideration of social economic status. So again, it's a right. Who pays for healthcare? So again, what about the choices? Sometimes clients may not be able to get a certain procedure done because the insurance say we don't cover that. So again, Medicare is a government allocation payer source. And for those clients with Medicare, again, it pays for inpatient care. It pays for some outpatient care for patients over the age of 65. So there's an age. Now, clients that are disabled, they can get on Medicare. Of disabled, I'm sorry, let me back up. Those clients that have end-stage renal disease or blind, they qualify for Medicare regardless of their age. Medicare also pays for preventative services, things like flu shot, immunization, medication. If a client is on Medicare Part A, they will not cover for prescription. They need Medicare Part D, and Medicare Part D also pays for. I'm sorry, let me back up. Medicare Part D pays for outpatient visits like doctor's visits, uh, office visits, things like that. These clients will have a deductible, and sometimes they would have a copay depending on what um what marketplace they join. Like for instance, United Healthcare is one of the marketplaces. Blue Cross Blue Shield. So depending on which umbrella they're under. So Medicare does not pay for everything. It does not cover everything. So the answer here is A. Medicare programs allows for hospice care, home care, hospital, home health, and some skilled nurse facility. That's part A. Part B covers prescription. Part D, like I said, it covers office visits. There are certain rules and regulation regarding services that are covered. Requirements must be met first. That some rules, some clients may have to get a pre-authorization or pre-approval before they can have procedure done. The only the extenuating circumstances would be if a client is like an emergency situation, then they wouldn't require pre-authorization or pre-approval. Utilization review. There are utilization review nurses out there. That's a specialty area where nurses go in, they look at charts, they determine whether or not the care was appropriate, whether necessary, and then it's covered. So again, that utilization review team looks at it. Also, you have your case managers in the hospital, and also they also look at care to determine whether or not it's reasonable and necessary. We know that healthcare market are different. There's a different unpredictability of demand. Also, consumer knowledge. Consumers know a lot about their. We go in now. We Google. We check out the internet. So we have again they make decisions based on whether or not they look at like reviews, like they may compare hospital A to hospital B. They may look at a provider, just look at some of the reviews that provider before they make a choice, and also lack of price competition. Now I do know that in rural communities there's not a real choice, because there's nobody to compete with. So again, most of those clients in those rural communities they have to get whatever is available for them. Okay, rationing allocation decision. Could be some ethical questions about that. Who makes the decision? Using what criteria? An example would be during COVID. Everybody couldn't get the COVID. You have to have a pre-existing condition or over the age of 65, I believe. So again, there were some ethical concerns about that. Also, we look at there are tools to help us to determine make allocation decisions and plan for expenditures. You have your when you're working in an organization, you're going to hear the term capital budget, operating budget, and personnel budget. Capital budget is those budgets that will, like, doing big renovations. Then your operating budget are things like what things, day-to-day operation, what goes under that, what goes under the operating budget. And then you have your personnel budget. This is what salaries and benefits falls under that category. So you're gonna hear that term. Then also the basic concepts of budget. You got to look at the revenue. Are we making enough money? Um, you know, into the unit for the good or services. You look at the expenditures. How much is it costing? Then your profit. You're making a profit. So you look at your profit or your margin. It's going to be your revenue minus your expenses. Your margin is going to be your revenue minus your expenses. So you're going to make a profit, or you're going to or not. So again, so everybody's in business to make a profit. So revenue minus your expenses equals your margin or your profit. Then again, like I said, type the budgets, the capital. Again, units to purchase for the next year. And then usually if there's a price on that, on those items again. So you put into the budget how much you're going to spend on, like I said, maybe renovation, and you can't go over that limit because again, you budgeting. Then you have the operating, like I said, expected expenses, volume projection, and this go on the operating budget. You got to have enough patient on the unit. So you look at your admissions, your discharges, and your transfers, and that's how you're going to come up with your operating budget. So again, if you're not admitting anybody to the floor, and then you discharging, guess what? Your operating budget is going to be offset. Again, that operating budget is going to look at, like I said, day-to-day things. Your line items like your supplies, your phones, small equipment, copy costs. Going back to that capital budget, now that's where you're buying big, you're making big purchases, you know. And then again, you have cost that changes. It's variable cost. It changes with volume of patients. So again, if you have a capacity on a unit, say 40 bed unit, and you only filling 20 beds, so again, it's gonna impact your operating budget because you're only gonna be able to you're staffing for 40 bed, but you only have 20 patients. So again, somebody, gonna have to be shifted to another unit, or that sometime that unit closes on. I've worked in facilities where the unit closed because they didn't have enough operating capacity. Then your fixed cost, it doesn't change with the volume of patients. Again, it's not gonna change because your cost is fixed. If the volume change, your fixed cost is not gonna change. So you have to go in and make some adjustment. That may, like I said, maybe shifting a nurse to a different unit, or maybe calling off a nurse or things like that. Personnel budget, again, it's a large unit expense. And then again, it's hours per patient day. Look at your staffing patterns. You'll have your full-time employees. All this is calculated in your personnel budget. So calculated to be like 280 hours, 52 weeks for a 40, based on a 40 work week. Also looking at productivity time, non-productivity time. Overtime is a big one. So if your manager tells you you need to get off the clock, you have to cut overtime. It again because he or she is trying to protect their personnel budget. So nursing costs represent about 50% of the hospital expense budgets because you have to have staff. What are economics of caring? So this include the value of nursing in the decision-making process for patient care. So it's our responsibility. The physical responsibility is to the patient, to the employing institute, and also to the payer of healthcare. So these are some different we as clinician, we are part of that decision making process. Physical responsibility to the patient is primary and most important responsibility, as I said. So again, we look at we provide the care in the most efficient way possible, combining our resources to maximize the benefit of the patient. So we have to understand the cost, and we also need to understand the different reimbursement system. So again, going back, we get the patient in, get them better, get them out. So it's our job to engage in early discharge planning. So we all know that discharge teaching starts on admission. So we're trying to get the patient in and out, in a reasonable time. And again, like I said, the physical responsibility to the institution, providing that quality patient care, using our resources wisely, and then understanding the prospective payment system. DRGs are just scratch that if they are no longer in existence anymore. So again, we look at documentation, accurate, precise documentation. Then again, we need to advocate for adequate staffing ratio. And going back to again those higher acuity patients, we know that the staffing ratio has changed some, but it hasn't got where it needs to be, meaning that you may end up with like 8 patients, 8 to 1. That's a lot, depending on again with the cure. The patient is sick now. So healthcare is projected to rise, which it is rising. So again, as nurses, we need to make sure we incorporate incorporate physical responsibility into our clinical practice. Like I said, being conscientious of the budget and overtime and things like that. Okay? So that's really all that I have to share with chapter 16, healthcare, economic healthcare delivery system. So I'm going to download this and upload it in the course. Thank you.